All right. Hi, everyone. I'd like to go ahead and welcome you to today's CPWR webinar on opioid use and worksite overdose fatalities in the construction industry. I'm Jessica Bunting. I'm the CPWR host for this event. I'm just here to make sure things go smoothly and provide technical support. So if you have any trouble, you can send me a message in the chat box or email me by responding to the WebEx registration or reminder email that just went out. If you are logged in but experiencing difficulties hearing the sound through your computer speakers, I recommend calling in using your phone instead. It usually works a little bit better. That information can be found in any of the event emails. Just be sure to disconnect the audio from your computer or turn off your speakers to avoid an echo. We will take time at the end of today's presentation to answer questions, but you can type them in at any time in the Q&A or chat box, and we'll do our best to get through all of them at the end. Today's webinar is being recorded, so I will share that along with some of the slides and resources that are mentioned during today's webinar in a follow-up email after the event. Today we'll be hearing from CPWR's Executive Director, Chris Cain, as well as the Director of our Data Center, Sue Dong, on why this is an important issue to address and what we're doing here at CPWR. So Chris, I'll hand it over to you to get us started. And you may be on mute.
I was. Thank you, Jessica. Hi, I'm Chris Cain. Welcome to the webinar. Sue and I are going to be presenting some new information and also some resources that CPWR has available now. Basically, what we're going to cover in this webinar is why this is an important issue for the construction industry, new data, new information that we know about opioids in construction, as well as some resources from CPWR. So why are we concerned about this? The information started to come out in late 2017 that construction workers are disproportionately affected by this overall societal crisis. Obviously, the opioids epidemic is affecting all Americans. However, this first study that came out of Ohio in late 2017 found that construction workers were at a more than 7 times greater risk for fatal opioid overdose within that state. Shortly thereafter, Massachusetts published an excellent report. Unfortunately, they found the same unacceptable risk for construction workers, that they were dying of fatal opioid-related overdose deaths at about 6 times the rate for all workers. Some of the information that we're going to be presenting in this webinar is new data that Dr. Dong has produced and her team in CPWR's data center, looking at information from the Census of Fatal Occupational Injuries. The CFOI data is a small portion of the overall overdose deaths in the nation, but it's important data. And that was the data source that was analyzed for our most recent quarterly data report that was published earlier this month. Also in this new data report are information from the Medical Expenditure Panel Survey on prescription drugs used by workers, as well as information from the National Survey of Drug Use and Health. Sue will talk a little bit more about these data sources and the many limitations that these data sources have, as well as some interesting results, some new results, and some surprising results. And with that, Jessica, if you could switch it over to Sue's presentation so she can present the information. Thank you. I'm going.
Hi, everyone. Can you hear me? If you cannot hear me, please let Jess know. I know sometimes people complain I speak in a low voice. Thanks, Chris. You gave the nice introduction. My presentation will focus on our recent report. Before I start my talk, I'd like to take this opportunity to express my thanks to all our audience and data users. Thanks for your continued support. Your feedback, suggestions, and comments help us improve the quality of data products. In my presentation, I'd like to talk more about data sources and terms and definitions from the corresponding data sources. But actually, this report covers 3 different sections, and each of them can be regarded as individual study because they used quite different data sources and definitions. And first, let's look at the numbers from workplace, from Safeway. I believe most of you are very familiar with the Safeway data. In Safeway, we reported both the 2017 to 2017 date, and we added the new date in 2018. But the majority of the report only covers the data to 2017 because when we started our work, the 2018 data was not available yet. And even now, we haven't received the research files from BIS. So overdose is a category of event exposure in the BIS OIICS the system. So that's version 2.01. According to this definition, we are able to separate the unintentional overdose and intentional overdose. Based on these definitions, we found the majority of overdose fatalities at work sites were unintentional. I included work sites in each of the slides just want to clarify. This only for work sites. So, because most of them, the numbers were unintentional, that this report actually only covers unintentional overdose fatalities. So, and we found unintentional overdose fatalities in construction workplaces increased 9-fold from 2011 to 2018, more than twice the increase for all industries. If you look at the year-by-year data, you will see in 2017 the number was 7. You might ask why we'd like to spend time on the small numbers, because even the number cannot show over the whole picture. These numbers is a very good indicator or important indicator of this issue. And from the previous chart, you cannot tell what is the overdose. That's why we broke down the overdose by source. That's the major category of codes in the OIICS. The little star means there are several subcategories under the number. So if you look at the next chart, you will see the majority of the source that is under drugs, non-medical. Nearly half of those fatalities at the construction work sites were caused by drugs, non-medical. And so I received a lot of comments on the category home. Now, home, first, I'd like to clarify home here is a category of the location coded by the BIS in the Safeway data. So about 43% of those fatalities in construction workplaces occurred at home. This, if you look at it in the detail, you would say the residential construction site it's just one of the subcategory. And many numbers were under home unspecified and home not elsewhere classified. So we thought it's better to use the category or the term by BLS, that home, that maybe that we can refer to as overall residential sites. And we did this on purpose. In the following charts, we'd like to, got disappeared, the little item.
If you
why is it disappeared?
Or try hitting the down arrow or the back arrow.
Oh, yeah, back arrow. Yeah, I cannot see that either. So sorry for that interruption. So, oops. I don't know why it disappeared. And
Sue, I can advance the
slide.
Yeah.
Jessica, can you please control that slide for me? Oh, yeah, I found that. Yeah, it's there. Sorry for that. So, yeah, I got it there. So, I showed that the numbers occurred on the home or residential sites because we found the number of workplace overdose fatalities was disproportionately high in residential building construction. You can see that the number is much higher than the proportion in the overall fatalities and then caused by other causes. That's not a surprise to us. The number of workplace overdose fatalities in construction was disproportionately high as well among self-employed workers. Why? Because we know many self-employed workers are working in residential construction. Even we don't know exactly how many. I just picked up some slides from the section 1. Section 2, we talked about prescribed opioid use because from previous slides, even we show the intentional, unintentional, and several different categories, still no any category show that's exactly opioid use. So that we use the MAPS data, which is a set of large-scale surveys of individuals and their medical providers and the employers and the insurance company. And we linked 3 data files from the household component by survey ID. And construction workers in our study were defined by those who are age 16 years and older and working in construction at least one of the 3 survey rounds in the year. And when we talk about construction, we'd like to include all of those who are employed in construction. I read some recent publications, and actually in their studies, when they use national survey data, they only include workers who are in construction trades and extraction occupations. And actually, only 62% of workers in that occupations were in the construction industry, with some typical occupations like the welders, like the heating, air conditioning, and refrigeration mechanics and installers and power line installers. All of those occupations are not included in construction trade category. That's why we used construction and based on the industry classification instead of occupational classification. From this data source, and we found 1 in 4 construction workers with work-related injuries used prescribed opioids compared to 1 in 10 of their counterparts who were not injured. The work-related injury, that's according to the MAPS definition, that's medical condition resulting from an injury that occurred at work. And a prescribed opioid and only include outpatient prescribed opioid. So we did some analysis by demographic categories. We found older construction workers and the white non-Hispanics were more likely to use prescribed opioids. Why older workers are more likely to use? Probably they have more chronic conditions such as MSDs. So construction workers without health insurance were less likely to use prescribed opioids. This is the findings I select from the section 2. The third section, we analyze illicit drug use using another national survey data, National Survey on Drug Use and Health. We found a quite different story from the prescribed drug use, opioid use. There are very complicated definitions from this data source. Any illicit drug use in the prior months that refer to a long list of the drugs, but in our analysis, we excluded marijuana. So the reason is then because the data this data set, I just want to add it to something else, stopped collecting industry and occupation information since 2015. So all analysis just to data 2014. So you know that now marijuana can be legally used in some states, so that we don't want to increase such a debate. We analyze them separately. So illicit opioid, there's a very long list of the drugs, and there's a group of questions regarding the illicit opioids. If you are interested, you can find this information on our website and on the NSDUH website. Using this data source, we found the younger construction workers were more likely to use illicit drugs, while Hispanic workers were much less likely to use such drugs. So we also found unemployed and uninsured construction workers were more likely to use illicit drugs than their counterparts. After I show you all these underlying factors which could contribute to illicit opioid use, that we may now be very surprised to see construction workers had the highest rate of illicit opioid use in their lifetime, about 30% higher than all industries combined. Why? Because we know construction workers are much less likely to receive insurance from their employers, and a construction job, you know, that's much less that's not secured. So that can be partly that explained why the high rate of illicit opioid was found among construction workers. So we do have a lot of limitations when we worked on the report, and the report only just included some of initial findings. We'll continue to work on that, such like that we will do the more statistical analysis, including multiple logistic regressions. I hope we can share with you some new findings in the near future. So that's what I'd like to share with you. If you have questions, I would be very happy to answer and in our Q&A. Thanks for your listening.
Okay, thanks, Sue. This is Chris again. And again, if you have questions, we'll be happy to do our best to answer them. And we will, if you can type them to Jessica through whatever means she's already explained in the chat box, in the Q&A section of this webinar. Even if you email her questions that we can't necessarily address during the webinar, we will come back. But I wanted to throw these two graphs up again. These are the state findings in Ohio and in Massachusetts that demonstrate that workers in our industry really do have elevated risk. But I also wanted to reflect a little bit on Sue's data for a moment. The CFOI data, the data of workers who died on the job, is we have to keep that in mind. It's a very low number as compared to the number of workers who die off the job in our industry. It's a tiny fraction of those overdose deaths. But why it's important is because it offers many more details about where the death occurred and some other circumstances surrounding the death. And it allows us, we hope, to see some trends which will allow us to thanks, you're on mute. Some of the information that it does offer is what construction subsectors are also more at risk, and it appears as though from the data that Sue analyzed that the sectors include the residential sectors. The workers are dying on home building sites, and workers within the NAICS code within the category of residential construction have a greater number of deaths. It also flags for us that self-employed workers or so-called independent contractors, those who fall into those categories, are at a disproportionate risk as compared to the rest of construction workers. Importantly, it shows that on-the-job overdose deaths are increasing, and they're increasing more rapidly in this crisis than they are in sectors outside of construction. So those are really important findings that Sue has gone over. I just wanted to reiterate. In the MEPS data, she showed that many more workers are on opioids after a workplace injury compared to non-injured workers. And it also shows a really unexpected result that overall construction workers are prescribed opioids at a lower rate than all workers. We don't know exactly what causes this and how it's related and why it's so surprising, but we'd really welcome ideas from people who are participating in this webinar and anyone else who can help us understand, what perhaps is related to this. We have some theories, but we don't necessarily know for sure. On the topic of illicit drug use, I think it's important. We can't talk about opioids in construction without acknowledging that, according to the data, that construction workers are 30% more likely to self-report illicit drug use. Bearing in mind that a 30% increase in this population in no way explains that workers in our industry are dying at 6 to 7 times the rate for other workers. That math simply doesn't add up. And other researchers have concluded that the higher background drug use is unlikely to account to the unacceptable rates of fatal overdoses among our workers. So I think the next question and the right question to ask is, what are we doing about it? So as this information was becoming very clear to the leadership of North America's building trades unions, NAPTU, President McGarvey established an opioid task force. And the task force was charged with figuring out what, in this case, construction unions can do in response to the societal crisis that was disproportionately affecting workers in the construction industry. This task force was established in the beginning of 2018, and the first order of business was to develop an approach to dealing with this. Just if you kind of step back from the problem, construction unions can't solve this problem for America, but they've felt that they did have a role in dealing with this issue, and the whole industry has a role in dealing with this issue. So a public health model was adopted to deal with this crisis, and in order to try to move the needle, we were able to adopt a prevention model where we look at primary, secondary, and tertiary prevention. And really, in our view, the big issue that we need to do in primary prevention is to prevent workplace injuries that cause pain. That's number one, and I think that's what construction, occupational safety, and health professionals have traditionally focused on, and it's what we at CPWR focus on and what we strive to do. So this is part of the work that we do at CPWR, is working with our industry partners to double down on the adoption of programs that reduce things like musculoskeletal injuries from moving materials on job sites. We looked at secondary prevention. So what happens if a worker's hurt? How do you stop a worker or try to intervene from getting their first prescribed opioid? And we're looking at that as education on effective treatment of injuries and pain for workers. So we're looking at that as secondary prevention. And then tertiary prevention, we consider how does the construction industry support workers who have developed substance use disorders. So looking at things like treatment and ongoing recovery support and recovery-friendly workplaces fall into that category. But really throughout this whole thing, the effort was important that we look at the awareness of this issue in the construction workforce, amongst the workers in the workforce and the employers in the workforce and other actors in our industry, and destigmatization of substance use disorder and the use of opioids was an important thing that was agreed to in the task force. So some other things that the task force identified are things that don't work. I won't go through them, but these I think are important that we acknowledge that a lot of the issues around substance use disorder really are difficult to deal with in our industry. Out of the beginning of the task force operation in early 2018, the priorities became pretty clear quickly, is that the task force believed that the industry needs resources with consistent information. They need education to encourage awareness of the issue and destigmatization. They need guidance for employee assistance plans and member assistance programs. They need vetted treatment centers. This came out of the task force as how do you pick a treatment center for a worker who has substance use disorder. That was an important priority. They need guidance for peer mentorship programs. And of course, everyone wanted to solve this problem immediately. So what did we do? CPWR developed some resources, a number of resources to support the task force priorities and priorities that we were hearing outside of the task force as well. All of these resources are available on this webpage that's on the screen in front of you. As Jessica mentioned, she'll be sending out the slides and a recording of this webinar, but also links to the resources that we have. These are all free for anyone to use and download, and I wanted to talk just a little bit about them. Very quickly after the formation of the task force, we developed a hazard alert card. This is a pocket card. We can send them out for free from CPWR if you give us a call or send us an email, or you can download an 8.5 by 11 version from our website. This is just a basic information to start the process, talking about it, thinking about it, and starting to destigmatize this issue. Likewise, we developed a toolbox talk, so you can do your first, do some basic training on the job talking a little bit about this issue, getting the ice broken, and starting to, address this issue head on. This is another document that we've developed that's available on our website. It's called a Physician's Alert or Provider's Alert, and this is similar to a series of physician's alerts we've developed for other topics that are intended for workers to bring to their doctors when they need to go to the doctor to deal with pain, for example. So this helps communicate in doctor language, we hope, that this is my work. These are the type of medicines I shouldn't have in my work, and also communicate about the issue of pain management for workers who work in the construction industry. We developed an infographic to share on social media and to raise awareness and point back to the resources we've developed on CPWR's website. And the most recent development was this month. We've developed an opioid awareness training module, and we've let it loose. And I wanted to say a couple of things about this training module. This is just a slide showing the objectives of the course. But the training module is not just a PowerPoint. It is an instructor guide, which is, I believe, essential for trainers to pick up and try to use this training program. Gives them the guidance, gives them the resources, the references, and allows them to be more than one question deep as they're presenting this training to participants. In addition to the PowerPoint and the instructor guide, we've developed some participants material. All three elements of this training program are in beta form, and we will be evaluating it in the next few months, and we will definitely be updating it. There are things in here that will need to be fixed, so we ask you to come back to CPWR's website if you download this training program to check back for updates, because it's absolutely important that we keep the best information out there as possible. The documents on the website are flagged as beta, as flagged with the date when they were released, as well as the website to return to download updated materials. So the next steps that we're doing at CPWR to try to address this problem is as I said, we're rolling out the training program. We're evaluating it in real training sessions, and we will be improving the training program. So definitely check back for it. Another really exciting thing that we're doing is we're contracting with an organization that specializes in developing communication methods around difficult public health issues. So we're working to identify how do we better talk about opioids in construction, and how do we better communicate prevention. Because most of the conversation on all levels about opioids is about workers who already have a substance use disorder and what's good and what's not good for those. And while that's very important, and there should be a lot of effort and attention paid to workers who have substance use disorders, we believe that addressing issues before they explode into a substance use disorder is the best way to go. And we need new ways to talk about it to get people's attention and improve the work we do on the prevention side. We're also doing what I would call a deep dive into peer support networks and how, in particular, around building trades unions and their employers and their communities, how do these networks work? We know a lot of great things are happening where, based out of the health and welfare plans for the construction workers, based out of the construction workers unions, there's a lot of great support systems that have been put in place, that have been operational for a long time. Some are really new. Some are at the international union level, so they're rolling them out nationally. Some are at the local city, state level. And so what we're doing is we're doing a close examination of those and trying to identify some best practices as well as research questions, things that we need to look into to figure out what really works, how to frame new construction or frame new studies and to share good information about peer support networks. And with that, I was hoping that we could get some questions that Sue and I can answer or look into, or suggestions. And I'm going to let Jessica handle looking at those questions and letting us know what they are.
Gotten a number in already, actually. So, the first one, how long is the opioid awareness training?
Thank you for that question. We tried to build it to be delivered in 2 hours. We've had some reports that it goes a little long. That was the target that the NAB2 Opioid Task Force asked for, and the presidents of the building trades unions asked us to do based on that recommendation. So right now it's a 2-hour module.
Just to chime in on that, and I don't know, Cora, I'll unmute you. But we did a webinar about the training recently for some trainers, and Cora had mentioned that while it is about 2 hours, there is some flexibility so that you can take from it if you need a shorter version and adapt it for the time that you do have.
Yes, it's been designed with questions and optional exercises that could be could be just made into didactic elements rather than participatory elements that could probably shorten it up. It also depends on if your training audience wants to talk. And if they want to talk, that's probably a great result. And so even if you don't get through the slides, although as Chris has mentioned, we are looking for folks to try out the training and to even administer a pre and post test so we can see whether it's meeting the goals for effectiveness and impact.
Thanks, Cora. And I am just looking at the presentation. I don't think the link for the training is included, but I will, again, link to that as well in my follow-up email of the resources that we talk about today. I'll try to capture in that email.
Yeah, and Jessica, that can be found from the main opioids web page.
Okay. Thanks, Chris.
Linked to that page that's on there.
Next question is, I was wondering if there was any link between opioid and drug use and mental health.
From what people have told me, most definitely, that definitely these things are linked.
Oh, can I add something? Oh, go ahead.
Just to mention, I can't go to a meeting anywhere anymore without people raising the issue of suicides in construction. We have a similar epidemic amongst our population of suicide. And for that reason, we've also established a suicide prevention page on CPWR.com, and we're trying to share information and resources from the best sources we have. We also address mental health in that 2-hour training program. And Sue?
Yeah, following the Chris's response, and we will conduct a study. We want to analyze the work rate, the mental health, drug use, and all other demographic and employment factors, and suicide, and actually not suicide, suicidal intentions. I think that it's better we know why they wanted to commit suicide when they were still alive. So I think that's very important, and that's part of our work we will do next.
Okay, thank you. Let's see. I just want to point out a comment for everyone, including our presenters, from Thomas Gunning in the Q&A section. This isn't a question, but it looks like he has the Building Trades Employer Council. Am I getting that right? Employers Association, Building Trades Employers Association, sorry, in Massachusetts, and they are doing a Building Trades Recovery Week, April 29th to May 3rd, and so he's put the information about that and a video from last year in the comments for people to check out. So thank you, Thomas. The next question is, what can a general contractor do to avoid this opioid overdose with their employees and those of their subcontractors?
That's a great question, and I think the first step is talking about it and bringing it out to the open. Recognizing that construction workers are often on high doses of opioids that are prescribed opioids. Using the awareness materials that we've created, the toolbox talks, knowing what resources are available for your workforce is absolutely critical. That's one of the things that we have up front and center in the training program, because when you start talking about this issue, invariably there are people who may need the resources that are available to them, either through their employee assistance program connected to their health insurance or a members assistance program established by their union. These are really important issues, and the first step is to talk about it, to break down the stigma around it, and to raise awareness of the fact that opioids, are a problem in construction and that there is help out there for folks. Of course, if you go to upstream, it's about putting in place good programs that stop workers from getting hurt. That's traumatic injuries like falls, but that's also musculoskeletal disorders, addressing ergonomic hazards in the job site. One of the resources we have at CPWR is a relatively new program called Best Built Plans, and it's all about helping contractors establish materials handling programs that reduce musculoskeletal risk for workers, about the strategies of planning the work in the best way possible to reduce those traumatic injuries that cause pain.
And this one is for Sue. Did the study specifically concentrate on Hispanics versus non-Hispanic workers?
Oh yeah, we included an analysis from all these the three data sources: the Hispanic and versus other ethnicity group, like a non-Hispanic white and a non-Hispanic black. Yeah, that's included in our studies. In the fatality numbers, if the numbers are, we do have the limitations of the numbers. If the numbers are big enough, we also report it. Yes.
Okay. Is there a connection between having paid days off and the ability to take time off and opioid use?
Well, yeah. So in our detailed analysis, we'd like to include the lost days also as the one variables in our study. Yeah.
And I think that's important to include, but that doesn't really get at the question about the fact that most construction workers don't have paid time off. So that has been definitely flagged by people anecdotally as well as in publications as contributing to this issue. The fact that a worker, if he doesn't go to work or she doesn't go to work, she doesn't get paid. So something that, say, an office worker gets a sprain, needs to take a day off to elevate their ankle. Construction workers can't take a sick day in many cases. So how much does that contribute to this epidemic that a construction worker may instead go to their doctor and be put on pain medicine so that they can continue to work through the pain. So I agree that's an excellent question. I believe it's completely connected to this. However, I don't know of any study that's quantified it. We'd love to see that study done.
Okay. I have seen construction companies start to purchase Narcan to keep on site for overdose cases. Are there any laws, guidelines to be aware of, or resources to help with this?
That, again, is a great question. I don't know the answer to that. I remember hearing that in the beginning, the task force members would tell me in the beginning of the task force that they were running afoul of some state laws, but I do not know specifically how that works out. I think you have to check in with your state laws. Maybe, Jessica, we can make a note of that and look into it, and if you can flag the questioner, we can see if we have any more information on that.
Okay.
But, I mean, that's actually a great practice in this day and age to have Narcan on the job. And there are state laws that are Good Samaritan laws that really eliminate liability for doing that. So, but I can't tell you specifically where they are and what they say.
Have you explored alternative pain management programs to recommend to workers?
We've heard about them. We've definitely heard about them and that they're effective. I was just trying to see if we have that in our physician's alert, and I'm not sure if we do. I can't read it that fast. But definitely we've heard that they're there and they're effective, things like acupuncture, physical therapy, and different, non-narcotic pain relievers, that they are very effective. And, some studies say that Tylenol works a lot better than opioids on musculoskeletal pain. So it really doesn't make sense that we have workers prescribed opioids for musculoskeletal pain.
Is there a reasonable suspicion training available through CPWR for supervisors to help identify potential issues with employees?
No, we don't have that.
Are deceased workers found overdosed on the job site counted in the BLS work-related fatalities?
That's a question for me. Yeah. The numbers we counted, the fatality, just on the work sites, that numbers are from Safeway data collected by BLS.
So do they count as work-related fatalities, though?
Definitely. All Safeway only cover work-related fatalities.
Are workers staging accidents to commit suicides on the work site?
Yeah, if that's that's some intentional overdose, that can be something like a suicide. We did some analysis on suicide. We will do more in the future, but the numbers are even smaller than the number of opioid the overdose fatalities. So, and that only very few caused by overdose for the intentional. If the majority of these numbers, suicide, were by gun.
Okay. I'm just going to read a note, since I just read that question, that said commit suicide. I'm going to now correct myself and read a note about helping to destigmatize the issue of suicide. Just that suggestion is to use better language such as died by suicide rather than saying commit suicide. So I just wanted to share that thought with people. And I am going to pause on the questions momentarily to unmute Cora again. Hang on a second.
Hi, everyone.
Cora?
I just want to raise another point related to alternative treatment for pain, which is that if there are workers who are facing opioid use disorder or just have high levels of opioids and such, and as a result have, a physical dependence upon opioids to manage their pain, and they wish to reduce their opioid use, this is also an area that's extremely important to focus on. What is going to be effective for construction workers to taper off of opioids and to, once they have developed a dependence and maybe even what they would regard as a substance use disorder, meaning that they can't quit if they want to. And that means there has to be programs that are able to integrate opioid use disorder treatment with pain management strategies, because of course it would be much more difficult to reduce or eliminate your opioid use if you are not also having medical treatment and effective ways of managing your work-related pain.
Okay. Thanks, Cora. All right, we have a few more questions. So this question is, are you using any questionnaire to measure pain? And I think a better phrasing of that might be, do we know of any questionnaires to measure pain to make sure that workers even need opiates?
I think we are not measuring pain at CPWR. So we're not prescribing opioids.
Right, that's why I sort of rephrased it to just say, do we know of?
Yeah, I'm not sure. I don't think that's a question for us at CPWR.
Is there any demographic information on locations where the opioid problem is the worst in the construction industry? Is it state specific, et cetera?
That's a question for me?
Well, Sue, you can answer on the CPWR data, and then I'll chime in.
Yeah, the CPWR data, we did report that. So we found this, if you look at our report, you will find the larger number were among the white non-Hispanics. Yeah.
And in the quarterly data report, there is information on generally across the country comparing the Northeast, Midwest, South, and West, and that the South had the highest number of opioid deaths in construction on the job. What we don't know is national data or state-level data like we got out of Ohio and Massachusetts, because you cannot get the same data in the overall statistics that tie back to an industry where somebody works or tie back to their occupation out of national data sets outside of CPWR data. I hope that answers the question, but if other states were to replicate the studies that the reporter in Ohio did and that the Public Health Department in Massachusetts did, that would be phenomenal. So we could see at the state level what type of occupation and industry folks were in who died of overdose in their states, because we simply don't know outside of those two state reports.
Great. All right. Let's see. I think that was all of our questions. Just going to draw everyone's attention to a comment that NIOSH has a fact sheet about using naloxone to reverse opioid overdose in the workplace, and I will also include that link in my follow-up email. And Cora just included a link to national level information. Great. If you have any questions that we didn't answer, or any follow-up information that you're looking for, or information to share with us, please feel free to email, let me put the emails up on the screen real quick. You can email Chris or Sue directly, or you can just simply respond to any of the emails from me, and I will put you in touch with the appropriate person. So thank you, Chris and Sue, for talking about such an important topic today, and thank you, everyone, for joining us.
Thank you.
All right, thank you.